Welcome to the Medicine and Science podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. This week, we'll be hearing why the NHS 10-year plan is unlikely to succeed.
We have this extraordinary asset that is 1.3 million people. If we don't lead and behave in a way where we're supporting them, nurturing them, encouraging them, and actually just winding them up and feeling like they're disenfranchised, that's really not clever.
Why delirium is still so hard to diagnose.
Just in the same way that someone can have an acute kidney injury or acute renal failure, we are really seeing that delirium is this acute failure of an organ, the brain.
And what a recent study published by the BMJ tells us about the patterns of injuries in Gaza and the needs of its population.
Even trying to analyze this stuff, you have to take a minute every time just reading through these stories. It's like you can't believe and fathom how these things are happening to people.
In July of this year, the government published their 10-year health plan for England. A new analysis just published on bmj.com takes an in-depth look at the chances of that plan succeeding and where the government needs to focus time and resources. So to discuss this, I'm joined by two of the authors of that paper, Bob Klaber, who's a paediatrician and Director of Strategy, Research and Innovation. It's quite a title, Bob, you've got there, at Imperial College Healthcare, and Helen Salisbury, GP and columnist for the BMJ. So first of all, thanks for joining us. And Bob, tell us a little bit about the gestation of this paper.
Yeah, thanks, Cameron. And we'd been having conversations across a wider group around with the BMJ Commission, and I think thinking about some very critical areas that health and care in this country needed to be thinking about in the run-up to the 10-year plan. And then, as you say, in July, the plan landed. It seemed sensible for us to sort of get back some of the people who've been involved in that commission, if you like, on an ongoing basis, to have a bit of a deep and critical think about things. So I hope we've pulled together some analysis that is both sort of realistic in its critique, but also sort of has a forward look and a sort of a hopefulness. And I hope that readers and listeners to this will get a sense of perhaps some of the things that those of us working and leading in the service can crack on and make a difference on, whilst also being realistic perhaps about some of the limitations of the plan.
Okay, Bob, thank you. Let's first of all go to Helen then. I mean, Helen, one of the obvious areas of discussion, if I can put it politely, in the plan itself was around what this means for general practice. Having reflected on it for a couple of months and contributed to the paper, how do you feel about it now?
I think it's really, really not clear what this means for general practice. I mean, they set forward this model of neighbourhood health hubs, which sounds a bit as if they're replacing GPs, or GPs will work in them, but they'll replace the traditional general practice. But then when all GPs thought, really? Well, I mean, tell us more. We weren't expecting this. They said, no, the GP contract is safe. And basically, we have no idea. And it's not even clear that the people who wrote it have a very clear idea what these new structures will be, where they will be physically, or what actually they will do. I think the other thing that is difficult to work out how it's going to happen is that if we want to invest more and do more in the community, and that may be great to have, so the patients are not travelling so much to hospital, and that would be lovely, and to have more resources on our doorsteps where we can use them, that would be great. If there's no more money, then that means shutting things in hospitals.
Yeah.
And the idea that you'd be able to do the shutting at the same time as doing the opening. In fact, you'd need to really overlap them to make sure the new thing works before you shut the old thing. And with no more resources, it's really difficult to see how that's going to work. So I know Bob wanted us to be optimistic about this. But I have
Well,
to say,
Bob will get his chance in a minute.
It's a kind of great, but how?
Yeah, I mean, I'll be honest with you. I feel you're being quite reserved here, Helen. I mean, the reaction... I've heard you say some strong things about this plan. And when I've spoken to other GPs about it, some of your colleagues, they've been pretty angry about it.
I think they are. I think they're very angry. They feel they weren't consulted. They have no idea this was coming. They have no idea what it means. And then there was this kind of rush to implement some of it, where it was kind of put a plan together, put in a bid, do it now, do it in the next 2 weeks. If you don't join in now and show that you're interested, you're likely to be taken over. At least that was the message people got. And it seemed quite threatening and not in the least bit collaborative.
No.
And for government, and they've said they want to work with us, they want to improve the NHS with its staff. You will help us build this great new improved NHS. And they're kind of, I think they're making everybody so cross.
It's not a good start to it. Bob, can I bring you in at this point?
So I think the thing that frustrated me a bit about the plan, and having genuinely read 168 pages of it and spent quite a bit of time kicking it around with lots of people, it's very technocratic. So the sort of theory of change, how is this actually going to happen? I couldn't get a sense of that. The bit that misses a trick for me is my experience of working in the health service all my career is every single person I've ever met wants to try and make a difference. They want to play their part. How you tap into that intrinsic motivation then at a national level thinks about, well, you need to look after people. You mustn't, leaving people feeling in the way that Helen has described how she and colleagues feels. It's not a smart approach.
I mean, Helen, how do you think we kind of move forward here with this? Because I think there's a big disconnect, isn't there?
There's a big disconnect. I think there's some really interesting stuff. There's a slight, I would say, obsession. That's maybe too strong a word, but there's a definite interest in this idea that somehow technology will save us and will reduce demand. The small steps towards being more tech. So that's in this week, there's been variations in the GP contract so that everyone can contact their GP practice all the time online. And GPs have been actually saying for a long time, but hang on a second, because if we're sifting through lots and lots and lots of queries, which might be about a stubbed toe or a slightly sore eye, that's going to take us away from having face-to-face appointments from the patients who are actually ill. We've not been listened to, and it's been very much coming from government that no, we want this easy access to GPs. These doctors are just being selfish. They don't want to work. You're going to have that access.
Yeah.
And that's what they're saying to patients. And the problem with this is it has so soured what was possibly shaping up to be quite a collaborative relationship between the new Labour government and the general practice community. And that has been trashed. Really sorry, but the relationship has never been worse, I don't think, than it is now. And on that background, it's difficult to see how we make this plan work. And if they did want to work from the bottom up and engage us and involve us and have all our ideas, well, they kind of just spavined that a bit.
Yeah. Bob, what are we going to do here? I mean, you want it to be we all want to be optimistic, constructive. I think we came into it all pretty hopeful. But then the realism, the sort of pragmatism of what's actually in the plan kind of hit us, didn't it?
Yeah, I think that's possibly been a doubly hard journey, if that's a thing. Of it's. I mean, Cameron, I know, like me, you love your sport. As I always say, it's the hope that kills
Don't
you,
start.
isn't it?
My teams have had a bad week.
Exactly. Yeah, exactly. Everyone, but genuinely, everyone who plays or particularly supports a team, will sort of know exactly what you and me mean. And I think, to Helen's point, there was a moment in time where actually the health service, in its broadest sense, sort of felt very hopeful, and there was a sense of freshness about possible sort of new approaches. I mean, I think it's interesting. I was smiling. I was looking back at what we sort of put the key messages in the paper, and sometimes you look back and think, oh, did I really say that? But actually, the key messages here are really good, and I think are really important on it. So one of the joys of doing this work was hanging out with Nigel Crisp. And Nigel, he was the chief exec of the NHS when the 2000 plan. And so what Nigel brought to this paper as well was a fantastic sort of, if you like, organizational memory that went back. And one of the things that I remember him talking to us, and Helen, myself, and the wider group about, was this bit about prioritizing. And actually, as a director of strategy, you learn this stuff. you have to prioritize. So I think that we've got to focus on our top priorities, and then we've got to be very clear about what is our theory of change. How is that going to happen? And then let's be honest about the prioritization of funding to support it. There's a second bit about says, look, we have this extraordinary asset that is 1.3 million people. They're part of our team. And if we don't lead and behave in a way where we're supporting them, nurturing them, encouraging them, then we're and actually just winding them up and feeling like they're disenfranchised, that's really not clever. It's not good psychology. It's not a good way to think. So we have to get back to stopping this sort of divisive approach, which sort of says, the staff don't care as much as we. No,
actually,
we
Bob,
all know
you've said that a couple of times. It's something you're really feeling.
Yeah. I think I just look at it. I think it's been a really poor tactic. I understand the essence of it. There's a piece around it, but ultimately it's just such a poor idea. You want to get people on board, and the language and the narrative actually does the opposite. It's just left people feeling arms folded.
Yeah.
Well, you'll go away soon, and we'll carry on doing.
Yeah.
And
then
it's
just on that. I mean, if I was to critique Wes Streeting, I think he clearly understands the NHS. He clearly cares. He gets the principles. He's a very clear communicator. I think he sometimes kind of starts barking up the wrong tree. And I think then where I think I have a particular problem with how he goes about it is that he can get very aggressive and negative with staff. And I think if I was to extend your analogy, you introduced sport here, Bob. I didn't. Let it be known. Is that if a manager or a coach starts criticising their own players, that never ends well. And he does that a lot. And I think he should stop doing that. Sorry, Helen.
Mr. Streeting came to a BMA meeting very recently and basically said that anyone who didn't like his online plan would expect that we were GP laggards. He used the word laggards twice.
Not a winning strategy.
It's not a winning strategy. It really is not a good way to win friends and influence people. And by the way, I mean, if you look at general practice is streets ahead of the rest of the NHS in terms of tech. And, we had completely electronic paperless systems,
true.
decades before hospitals.
No, I agree with you. And also, I think it's a pretty poor thing to do, actually, where you've got, a group of professionals who are, you've got to say, are smart, motivated, dedicated. I mean, in any profession, you've got some people who don't fit all of those criteria that I've mentioned. But, largely that's what you'd say about GPs and doctors and health professionals, but particularly GPs. And you're overworked. There's too much demand. You want to do a good job. And the health secretary comes in and tells you you're laggards. And actually, I think the other problem with it is that he's won over by tech. But actually, some of us care about the evidence and whether these things actually improve outcomes and the running of the service. And so you're actually being, in my view, on the side of patients if you say, well, I'm not sure this is the right thing to do. And also, I think we keep seeing report after report. I was just reading a paper last week. I can't remember what it was from, just yet another paper, which was saying the thing that people are most bothered about is continuity of care in primary care and general practice.
Yeah, and Cameron, in the I think one of the things we out very early in the paper is the evidence behind many of the things in the 10-year plan, and if you like, the sort of smorgasbord of stuff, of ideas, and there's some really interesting ideas, but actually some of them have got evidence behind them, and others have actively got evidence that they don't really make a difference, and they're sort of slightly rehab. So there's something about us being really smart about some of these things, but the starting point has to be that the vast majority of our NHS staff are deeply motivated to try and make a difference. How do you ignite that? I guess that's the bit where I'd get my hopefulness, and the piece we've put about agency feels really, really important. So I think this is actually redeemable. It requires a bit of humility from our leaders.
When you say leaders, you mean the politicians?
I mean both. I mean, I think political leaders, and I mean, clinical and managerial leaders across the NHS.
Okay.
And
you're one of those.
Yeah, exactly. And I think there is a piece about rubbishing each other. We start to get into a really dangerous cycle here. So we've got to big each other up a bit more. We've got to look after each other across, Helen and I sit in a hospital and in a primary care setting. How do we work together to build this stuff up? That feels really important.
We're going to see at some point a delivery sort of plan. We haven't got that at the moment. I mean, what would you like to see in that?
I don't know. I think we have to be hopeful. I guess
Okay.
I get my hopefulness from the people that I have the privilege of working from, of learning with. As Helen alluded to, I feel incredibly lucky that my clinical work in an elective setting is all out working essentially in what I would call good, neighborhood type spaces, but working from learning with colleagues in primary care. And I think the people are the answer. Now, tech can enable people in really smart ways. I think the conversation about continuity, technology can also help us with that continuity.
No one's saying tech doesn't have a role.
Exactly.
I mean, we're not saying that.
But fundamentally, care, the essence, it's about relationships, it's about trust, it's about listening, it's about compassion. And I think let's keep that at its heart. And the hopefulness has to come from people. I mean, care is about people. This is a people industry.
Thank you both.
Thank you.
Thank you, Cameron.
And Helen and Bob are both part of the BMJ's Commission on the Future of the NHS. You can find out more about that on bmj.com, and we'll also add links to the podcast notes. Now, let's talk about delirium. The frequency of delirium is relatively high, between 1 to 2% in the community and as high as 14% of those aged over 85. Despite this, it remains an under-resourced condition, especially compared to other age-related mental disorders like dementia. Mankeet Louis, the BMJ's features editor, finds out what impact that's having on patients.
I'm Mankeet Louis. I'm the International News and Features editor here at the BMJ, and very delighted to have our regular freelance journalist, Chris Stoker-Walker, with us to talk about his feature on delirium. Welcome, Chris.
Thanks for having me, Mankeet.
Just to start off with, I mean, can you tell us in a nutshell what is delirium?
Yeah, so it's this really sudden onset state of basically acute confusion that we don't really know fully why it's brought about. Sometimes it can be because of illness, sometimes it can be because of infection, sometimes it can just be because the environment in which a patient exists changes. But it is a kind of alarmingly common illness that often gets bundled into things like dementia or Alzheimer's, and sometimes gets confused with that, and is unfortunately, I think, often overlooked within the health service because people don't necessarily know how to respond to it.
And I mean, the lead-in of the feature is it's quite a personal story for you. I wonder if you're comfortable to kind of talk a bit about your personal experience with delirium.
Yeah, so I've kind of experienced this firsthand, and it was part of the motivating factor for wanting to write it. So around about sort of Christmas time or so last year, my granddad, who was at the time 92 years old, started to feel pretty unwell. He had atrial fibrillation that had been picked up when he had broken his hip at the kind of grand old age of 90. And had been put on tablets to try and solve that, but had caused maybe some swelling in his legs, what many of our listeners will know as a kind of classic, I suppose, route for an elderly patient. But around about Christmas, something seemed to change. They were amping up his medicine, to his water tablets effectively, to try and get rid of the excess fluid around his legs. And he started to change somewhat. He was becoming more lackadaisical. He was getting more confused. And it was really only when he started to actually, see things. So he lives over a park in the northeast of England and started seeing horses running across the fields that he could overlook, or imagined that he was in a hospital and waiting for an appointment when he was actually just sat in a chair in his bedroom, that we started to think that was quite concerning. Early this year, things took a turn for the worse. He was basically unable to move. He didn't really know where he was. He was admitted to A&E by paramedics. And finally, we had a label for this thing, which was delirium. And basically, looking back, we think that he had delirium, that kind of onset of confusion and not really knowing what had happened for quite a while. He was treated in hospital for 3 months or so, kept being quote unquote medically optimized, ready to be discharged. and then suddenly the delirium would flare up. Hospital wards are never really great places to try and recover from delirium, which often requires stability, routine, calm, and a sense of sort of sereneness to get yourself mentally back to normal. And unfortunately, he ended up basically getting worse and worse. Every time that he was due to come out, he wouldn't. The delirium started getting more harmful. He started falling and trying to get out of bed. He wasn't eating, he wasn't drinking. And eventually, unfortunately, he died in April. Now, not of delirium. It's kind of sort of similar to COVID. You often die with delirium. He ended up dying of an infection. But it was only after he died and I started telling friends and family of that and explaining that he had delirium that I realized actually basically everybody knows someone who has had delirium.
One of the things that comes out of your feature is the fact that family in particular seem to notice it a bit before, but they're not really sure what's going on. But also, crossing with that is the fact that delirium can be not cured, but it can be overcome a bit more if you can notice it earlier and then try to do something to get at the root causes of it.
Yeah, so first things first, we need to point out delirium is reversible. But the problem is you have to learn what has caused the delirium, try and figure that out in order to rectify it, to kind of correct the problem here. But the way that you often identify delirium, and the way that my granddad's delirium was found, was through a relatively simple test. It's called the 4AT. It's developed by a guy called Alistair McCulloch. He is a Scottish researcher, a really strong delirium advocate who believes that we need to do more for this. And it's just asking simple questions at the point of admission or during a hospital stay, where you basically try and understand the level of confusion that someone has. So you ask them simple questions like to name the months of the year backwards, or where they are, or what year it is, and things like that. Questions that basically you wouldn't get if you were in a delirious state, because you don't really know where you are. You have really bad hallucinations often. That then gives you that kind of positive delirium diagnosis, and you can then start to work on doing things about it. The problem is that is often not always done, and because it's not always done, delirium often goes untreated. And actually, it's a kind of £10.8 billion problem. There's been research done that suggests that actually if we treated delirium better, we could save that amount from the NHS because of the impact that these delirium patients have, often filling up hospital beds and causing other issues in terms of getting coverage and care.
You spoke about dementia kind of earlier. I'm thinking in terms of the funding and the intention aspect, how much is it useful or not useful that it is often bundled into dementia, even though it's different?
One of the challenges that I think delirium has is that it often just gets rolled in as dementia or Alzheimer's, whereas it's actually similar but distinct as well. And you only need to look at the funding gap between the two to get us this sort of indication of quite how much more work there is to be done. So since the millennium, delirium research has received around about £27 million in funding. Now, that sounds like a lot if you're not experienced in the world of NHS funding and medical research funding, because actually that £27 million is just a smidgen more than the amount that was devoted to dementia research in just 2024 alone. So a quarter of a century of research in delirium, we've had the same amount of financial outlay as you get for dementia in just 12 months. That, I think, really tells you its own story.
After my conversation with Chris, I wanted to know more about the medical science of delirium and the insider perspective for how the NHS handles the condition. I spoke to Elizabeth Sampson, Professor of Liaison Psychiatry at Queen's University of London. So Liz, if you could start by telling us, what do we know about how delirium works?
Well, I think that's one of the fundamental questions, really. There's still so much that we don't understand about delirium. But I think increasingly over the last 5 years, we've come to realise that delirium is not a benign state of confusion. We have increasing evidence of really profound changes that go on in the brain. So we can see reduced metabolism of glucose in the brain. We see disconnection, what we call neural disconnectivity between different parts of the brain. And increasingly, we are conceptualizing and researching delirium as acute brain failure. So just in the same way that someone can have an acute kidney injury or acute renal failure, or there can be an acute respiratory lung failure, we are really seeing that delirium is this acute failure of an organ, the brain.
And two of the things that you said in the article were quite striking. I mean, the first is that it isn't taken seriously by many healthcare professionals. But the other thing I noticed was that, you know, it is hard to tackle because people don't understand it. There's not really a cure or treatment. I mean, are those two things linked? Is the latter the reason for why it's not taken as seriously, because people just don't know what to do about it? They don't even know what it is, really.
I think so. So firstly, lots of people don't know what it is. They often see it as kind of a benign syndrome where people become confused, or they might even have some psychiatric problems, and it can often be misdiagnosed or blamed on that. And it's a very complex issue. But also, we do know that there are certain things that are very good for treating delirium, but they tend to be what we call multi-component interventions. So you need to do lots of things for the person at once. And the underpinning kind of theory and action behind these multi-component interventions is that you are decreasing stress on the brain, you're decreasing cerebral stress. So you are making sure someone's got their glasses and their hearing aid, you're treating any pain, you're orientating their sleep-wake cycle by keeping them awake during the day and asleep at night. And those things can be very, very difficult to do in an acute hospital environment. And people, I think, can just get overwhelmed. They don't know where to start when they're faced by someone with a very complex case of delirium. And I think one of the things that we really need to do as a practice and as a research community is to really look at what are the key interventions that you're going to be most effective for treating delirium. You know, which one of these things, apart from trying to find the underlying cause, gives us most bang for our buck when we're treating someone with delirium. And I think all of that collides with very, very long-standing ideas that when someone's delirious, they're just pleasantly confused, which we know isn't the case.
And I got one side question, which is that during the pandemic, the COVID pandemic, one of the interesting things I remember reporting on was the fact that there seemed to be increased cases of delirium because there were supposedly because there were increased infections, and COVID was the insult that was causing the onset of lots of delirium. I mean, can you speak a bit about that? What do we know about that? And is it a proven case that is happening?
Yeah. I mean, there was absolutely no doubt, I think, at the time that we saw increased delirium cases. And we would expect that. You know, COVID was a severe infection. And like all sort of infectious processes, you get a release of cytokines and inflammatory factors. And that's happening in the periphery, in the body. But the same process is going on in the mind. So what was interesting at that time was that we started seeing reports in the literature about a whole new condition called COVID encephalopathy from some specialities, as if they'd discovered a whole new problem. And actually, most of us in the field instantly recognised that COVID encephalopathy was not a new thing. It was delirium, and that's what we were seeing. In a way, COVID really unmasked neurological vulnerability in quite a large population of people and caused them to get delirium.
And it makes a lot of sense as well, since that was obviously the vulnerable population that would have been most affected by COVID should they unfortunately get it. I mean, it's interesting because they say that should have highlighted it much more. And Chris spoken to us at length about awareness and the fact that it's still not, as you said earlier, it's not a very well-known term or condition, even though it is so common. Do you think that has helped at all? Is it better than it was pre-2020, or are we still basically in the same place?
I think, unfortunately, we're still in the same place. I think the overwhelming nature of COVID for health systems meant that, again, things like delirium were really at a lower level of priority. I think what Chris said in his article about delirium being often encountered but little spoken about is really powerful. And that happens at the levels of patients, hospitals, hospital managers, all the way up to sort of health and policy world. We had a very large amount of attention on delirium and dementia in patients in acute hospitals from NHS England and the Department of Health and Social Care round about the sort of 2010 to 2016 period. They put in quality markers. Hospitals were monitoring and collecting data on how many people were being screened for delirium and dementia. Those care quality indicators, which were known as sequins, were kind of very quietly retired around about 2016, 2017. While those care quality indicators were in place, we saw rising recognition and documentation of dementia and delirium, and there's some evidence to say that's slipping down.
And my last question is, what one thing would you change right now if we could change it to make things better?
Test everyone who comes into hospital for delirium if there's any suspicion of it. So we have NICE guidance that says very clearly that older people or anyone at risk of delirium should be screened with a nationally required screening test, the 4AT test. It's a quick and simple test. And we're still really struggling to get people to do that at the front door. So that would be my ask, if we could just test it and also document it. So then we start seeing delirium properly coming through into NHS data sets. That would be the first step and a foundation for then putting in all the other changes and research that we need.
Finally, this week, we have some new data on Gaza. We've been reporting on Gaza for the last 2 years, and we've seen how difficult it is to get accurate data from a conflict zone. But this week, we published some research which aims to document the patterns of war-related injuries in the population there. Navjot Lada, our UK research editor, spoke to the authors.
My name's Navjot Lada and I'm a clinical editor at the BMJ, and I'm joined now by two authors of a research paper that we've recently published on patterns of war-related trauma in Gaza during armed conflict. Welcome to the podcast, Omar and Ameer. I'll just start by getting you to introduce yourselves.
So my name's Omar El-Taji. I'm a urology resident and PhD fellow based between Manchester and Liverpool. This study came off of the back of some of my discussions with Ameer following returning from Gaza back in May of 2024.
Great, welcome. And Ameer, tell us a little bit about yourself.
So my name is Ameer Ali. I'm an ophthalmology resident based in Yorkshire. And as Omar was saying, this research was kind of based on his experiences, but just our kind of wider imperative to try and help what's going on in this over there.
Let's follow up from that about what prompted you to do this study. Tell us a little bit more about what you were hoping to achieve when you set out to do this, Ameer.
So our kind of aim for this study was to just find out what's going on in terms of understanding the kind of clinical implications, what people are actually seeing. I think we repeatedly see a lot of medical doctors and physicians and nurses and healthcare workers stationed in Gaza post about these and describe these harrowing stories. And I feel like over a period of time, that information kind of gets lost in the news cycle. So I think as an effort for our part, we wanted to kind of help assist that description and kind of collate all the different experiences people are having to build a kind of effectively a body map to prepare fellow healthcare workers for when they do go to these places and kind of are prepared to deal with all these kind of different tragedies and different complications.
Okay, so from what you're saying, it sounds one part medical literature informing people that might help further clinical management, I guess, in Gaza. But then also there's something important there about bearing witness and documenting what's happening too.
Yeah, so, during the time that I was there, we saw a lot of difficult clinical situations where sometimes you'd see injuries that you'd never seen before. And then when you look into, where can I understand what kind of injuries are occurring, you start to look around. And unfortunately, when we looked, we found hardly anything. Now, What's important to note is that there is a formal way of documenting injury patterns and fatalities, and that's through the WHO. It's very difficult to get granularity within that data. So they can mention how many people have been killed and how many people have been wounded, but it's a lot more difficult to identify the exact type of injuries. And so when that is lacking within the literature, it's then very difficult for both non-governmental organizations, but also for the WHO as well to plan the health needs for the region.
Yeah, so it sounds like this research was planned to fill an important gap. But as we know that, doing studies in any conflict-affected area, let alone somewhere that the UN attests as a site of a genocide, is really, really hard to do. So tell us a little bit about how you went about trying to study this. Because for any study design, you're always thinking about the methods and making it as rigorous as you can. What did you plan to do, Omar?
It's very difficult to do such a study. And so we thought, okay, what would be the best way to try and extract this kind of data? And so we thought, well, we know that healthcare workers, keep logbooks and keep tallies of what kind of injuries that people are presenting with and how they're being treated. And so it was really Ameer that then came to me and said, well, let's do a survey. And I think that was a really, really good way to try and extract this data. And the first thing we thought was, how can we try and standardize the type of injuries that people are reporting as good as possible? So we essentially, brought together healthcare workers, experienced healthcare workers, to try and identify exactly which injuries are the most important, and then standardize it in a way by using ICD-10 codes. And so we had a Delphi informed consensus, which had 2 rounds where we identified ICD-10 codes and how the structure of the questionnaire or survey should be laid out. And I think what we had at the end was a really robust survey where we could identify as many of the injuries as possible and have it in a very structured manner.
And how did you identify who to send it to?
There's a very large community of healthcare workers, and we all, know each other rather well. And even if we haven't been deployed at the same time, we often, communicate quite regularly with each other, because you want to know, what kind of things you need to bring in, what kind of injuries are you seeing, and so how to best kind of prepare yourself. So that was one thing. But I think the way that we structured it a bit better was that we sent it through NGO rosters.
I think the difficulty a lot of people face is actually completing the survey, in the sense that, where's this data going to go? What's the implications that it's going to have on my personal kind of livelihood? Because I can understand a lot of people, once they've been to these places, and right at the beginning, there was a lot of contentions about what's going on. But what is the wide implications of my job role? Is there some sort of surveillance things going on? So I think a lot of people were hesitant to filling it out. We did eventually get a reasonable cohort of participants in our study. And I think the other thing we did kind of concentrate on was a lot of international healthcare workers, to kind of provide that global opinion that it's not just one group of people from one area that are seeing these things. It's people from everywhere with a varied experience.
What I would say is that Palestinian healthcare workers were not included in this survey. And the reason for that is because of their safety. We know that Palestinian healthcare workers have been killed and they have been imprisoned, and especially those who voice opinion. And so we did not want to allow that to happen to any of our colleagues.
Mm. And can you summarize what you found?
Yeah, so the results were pretty stark, and there was a lot of polytrauma. 70% of healthcare workers reported that they were dealing with polytrauma. There was 18% burns, and that is a very large amount. especially when you compare it to other literature. And from the burns, we saw about 30% that were third or fourth degree burns. And as you know, third and fourth degree burns are significant burns. They're very deep burns, and they require a lot of treatment and rehabilitation for, years to come. That was really our main finding. But one part of the study, we also looked at mechanism of injuries. So we looked mainly at gunshot and blast injuries. And what we found was that the vast majority of gunshot wounds affected the limbs, and the shrapnel injuries affected pretty much every part of the body. It really, that kind of data talks for itself.
And it was difficult to read and kind of collect the data, purely because the fact you're just seeing children with horrendous injuries, and there's nothing in the literature that could compare to these things. A lot of the kind of free text responses that we received were cases that are completely unimaginable. These would be a case report in any other Western country about how a child with multiple fractures, disembowelment was managed. But this is something you're seeing on a daily basis in an environment that's not equipped to kind of manage any of these things. So it was just terrible to read. It's terrible to kind of even trying to analyze this stuff. You have to take a minute every time just reading through these stories. It's like you can't believe and fathom how these things are happening to people.
The evidence that we're presenting in this paper is evidence that has been out there, but it's just been fragmented. All we have done is bring it together. We know what is happening. We know civilians are being killed en masse. We know that aid has been restricted. And you can see in our paper that there are, many of the healthcare workers reported malnutrition. And this was at a time before malnutrition or before famine was reported in Gaza, And so what do people think about how these injuries will then heal, even if they've had surgery or they've had the treatment that they needed? How is it going to heal over the course of the next year or so? Well, it's not going to heal. These patients, unfortunately, many of these patients, especially the patients with burns or those who have been amputated, they will die because they don't have the adequate nutrition to help their wounds heal.
I think the other point is also if we reissue, because if you remember, we sent this survey approximately 8 months ago from this interview. And if we did the same survey now, the clinical picture would be completely different, if not worse. A lot more chronic complications, a lot further disease advancement. It's slowly getting worse and worse every day. And I think any data we have, it's a time perspective, it's time stamped, but at the same time, you need to have the understanding that it's only getting worse. There's no sign of improvement.
That article, Patterns of War-Related Trauma in Gaza During Armed Conflict, is accompanied by an editorial. It also has an opinion article with it from the authors, which explains the human cost behind those numbers, and it's all linked from the podcast notes. That's it for this week. We'll be back in a fortnight with more medicine and science. Until then, I'm Cameron Abbasi. Thanks for listening.